All right, we're going to go ahead and get started with session 2 now. This is our first doctor's session of the event today, and we have a really special group of doctors here today. To me, these doctors represent a number of really just extraordinary things, a balance of realism and science and clinical care and compassion, obviously, otherwise they wouldn't be coming to hot, sticky DC for this event in July. Insight into the types of things that we go through. And another common thing to this group, I feel, is you are likely to have benefited from the work of these doctors, even if you've never heard of them, just through their contributions to ophthalmology. A couple of quick prefaces before we start. Financial disclosures. This is something that's always done at medical conferences, so we decided to do it as well. And also, to the extent that we have Q&A sessions after any of the doctor panels, I would just ask everyone to be mindful of the fact that no medical advice is going to be given here, so you want to keep your questions to things that are broader and not personal to your medical situation. All right. You can see their full bios in your programs that everyone has in your bags, so I'm going to leave the credentials and everything to that, ask you to read those. I just want to share a little bit about my personal connection with each of these doctors. I'm going to start with Dr. Brown. Dr. Brown has been there for me personally as an educator and a mentor and a very dearly loved friend for almost 25 years. If you are someone that has ever felt that I was helpful to you in some way, personally or through any of the sites and pages we've created and things, you need to also thank Dr. Brown because of how she has been my support in all of this time, how much she has taught me. She also serves on our board and has poured thousands of hours into the work of the foundation, particularly our eye drop safety program. Dr. Chiu, I first got to know of when she started the pros service at USC in LA, and that was really exciting to me because this is in an era when not too many people were hearing about scleral lenses. As Kathy shared earlier, this was not something that was commonly recommended for people with dry eye. So knowing there was a way for people to do this treatment on the West Coast or anywhere other than Boston at the time was a really big deal. Later, I got to know her personally. We would meet up at a lot of conferences, and I'm very proud to say that she's serving on our board as well. Dr. Galor represents a couple of things to me. One is her research in ocular pain is a really big deal. If you are struggling with ocular surface pain, she has been your champion, whether you know her or not. And she is a passionate educator of her peers. So those of us who have felt that our eye doctors did not know enough about eye pain, she is working to change that. Dr. Jacobs, I have known for almost 20 years from when I first went to Boston site for treatment myself. She was the medical director there for about 12 years, and I hardly know where to start here, but she is a heavyweight of heavyweights and certainly one whose work, again, has benefited you, whether you know it or not, pioneering areas in just awareness of and the science of eye pain. So can we welcome all our doctors, please? All right, we're going to go straight into our discussion then. Our first topic might be a little bit controversial. Is dry eye actually a diagnosis? Can I ask somebody to volunteer to be the first one to grasp this nettle? All right.
I'll volunteer. So you're stealing my thunder a little bit for my talk, but that's okay. It's good to ramp people up. I honestly don't accept dry eye as a diagnosis. That's a little challenging. Here we are, dry eye foundation, dry eye zone. It is the code you need in the ICD-10 to get paid for certain things. Certainly, drugs are labeled for dry eye, so it's part of FDA approval. But I find it very problematic when I'm treating a person in my chair. And if they tell me they have dry eye, I say, okay, that's interesting. And then I say I don't accept that, and we're going to drill further into this. I do like to say people have ocular surface disease, and I do believe there is something called aqueous deficient dry eye, and everything else I feel is misleading. It's a wastebasket and ends up being misleading for patients. So I'll stop there. I know that's controversial, and people can expand a little further, but.
Definitely singing from my song sheet. I mean, if I thought we could get away with calling the foundation the Ocular Surface Disease and Ocular Surface Pain Foundation, problem is nobody would find us.
I would love to add to that, because Deb and I have been talking about this for years. So I think terminology is really important. And for me, dry eye is very similar to back pain. I mean, it's definitely a concept and it exists, but if you go and see your doctor and you say, I have back pain, the next question would be, why do you have back pain, right? You can have musculoskeletal pain, you can have a nerve problem, you can have a bone problem. So for me, dry eye is the same way. It brings someone in, and just like Deb, I just never stop there. It's okay to start, but then the question is, what exactly is your dry eye? Is it more symptoms? Is it more signs? I like how you look at disease versus pain. Is it both? And again, I think what we heard about so nicely was everyone's underlying contributors are different. And so to me, it's really about finding the contributors in an individual patient. And as long as we keep that in mind, I'm okay with it. What I have a problem with is this idea of dry eye is one thing and you stop there. And so to me, it's about changing the way we think about it from a starting point to an end point, right? It's the starting point, not the end point.
I love that framing for it. So as a patient, if what I'm told is I have dry eye or dry eye disease and nothing else is volunteered to me, what can I do? What questions can I ask to get to that next place with it? Any of you, really.
I mean, for me, it's, so what is the cause of my particular dry eye? Knowing that dry eye is not one thing, the next question is why, what are the contributors in an individual patient? And so I think education is really good because we've already heard about some of the contributors. Anatomy is a huge contributor that is often overlooked. And I have to say that facial features is really a rare cause. I mean, there's so many common causes like excess conjunctiva or not closing your eyelids actually is really common, but it's usually not due to all these other things. But anatomy is huge. Tear gland issues are huge in some people, but not everyone. Environmental issues are huge. A lot of people don't realize that they have allergies or other issues in the environment. Stuff in your body is huge. And you notice that everyone has, right, you can have more than one thing, people are humans, but the idea is what is the biggest contributor and then what's next? Because it's really important to try to address different things in different people. And so coming in, kind of knowing what the different contributors are, you can ask your doctor, okay, which one do you think is most relevant for me?
I think getting back to our initial question of is dry eye a diagnosis, it definitely exists. We need it to bill for your exams and to get you the eye drops you need. But I think it's kind of an easy, sometimes a cop-out answer because maybe somebody isn't taking the time to dig deeper as to why you have symptoms. And I think a lot of patients earlier in our panel stated that they had to be their own advocate, and they really helped themselves the most because dry eye is not detailed enough. So when someone says, oh, you have dry eye, maybe if you've gone to different eye doctors, that's their way of, okay, you have dry eye, here's an artificial tear, I'll see you in a year. That's really not maybe the best way to go about it if you continue to be symptomatic. So I think digging deeper and really resorting to having the right team for you, whether that's a hematologist, a dermatologist, a rheumatologist, ophthalmologist, I'm an optometrist. I think you need the right group of providers, and it's not just one person that can take care of your eyes, but it's really a whole team of providers and specialists to take care of your whole body, because we know that systemic disease, environment, your job all play a role in dry eye. So it is a diagnosis on paper, but it's almost like a cop-out answer, and you need to dig deeper into what's the cause. So.
Awesome, thank you. Does anybody want to build on that team theme? I mean, who might I need on my team, depending what's going on with my eyes?
That's right. So it depends on why you have dry eye. And so people who have a systemic autoimmune condition, oftentimes a rheumatologist can help, but people who have really bad rosacea, and that's causing inflammation in their eyes, they may need a dermatologist. And so really, to me, it all starts with what is going on with you in order to find the right team. And I think it's really challenging until you figure out individual contributors. So to me, that's the starting point.
Anything you want to add?
Yeah, I have something to add because I want to follow up on what Gloria said. Dry eye is a cop-out diagnosis. And I think the reality of healthcare today is throughput and getting people into your chair and out of your chair and out the door. And our construct of health and disease, it's a Western one, I guess, is that you have a diagnosis, a problem, a physical problem, a physiologic problem. There's a medicine, it makes it better, you're cured, you go away. And doctors, both MDs and ODs, optoms, both are trained to name, identify, and treat like that. And in eye care, we're basically trained to look for sight-threatening disease. And although there are exceptions, generally in the dry eye world, it's generally not sight-threatening. It's life-changing, but it's not sight-threatening. And the fact is, you get screened in, the dot can look and in about 30 seconds tell if it's a sight-threatening process. And the rest of the story is getting you out the door. And this is true for all eye doctors, sadly. And it's even true for many medical doctors. So you have to find someone who's interested in you and your problem. And it's really hard to say what specialist that's going to be, because there are good and bad actors in every specialist. But it's got to be someone who listens and is interested, and ideally doesn't just have one thing to sell, okay? When somebody only has one thing to sell, they're going to match what they're selling to what you have. And that's very hard to sort out as a consumer and a patient. So I don't exactly know what specialty. Even, among neurologists, I like to say the headache specialists are going to be, well, there are pain doctors, but a lot of them are of the anesthesia flavor. They want to inject and send you on your way. And that works for certain things. Of course, many will say, well, eye pain, they're flummoxed. Psychiatrists don't want to treat eye pain because they are afraid, everybody's afraid they're going to miss something. So I really think the eye doctor has to work in tandem with whoever else it is to be reassuring that there's no progression or sight-threatening process, while the other person helps to sort out, or maybe the eye doctor will decide to work in the pain domain. That's what I hope. So that was not a very direct answer about what specialist you need. But it's really a willingness to engage, a willingness to think out of the box, a willingness to collaborate, and someone with more than one thing to sell. So I think dry eye, MGD, those are stepwise. There's one thing to sell. I don't accept either of those, any of those, in any patient I see. Now, by the time they've come to me, most of them have seen a lot of other docs. But the starting point is, I don't accept that. I ask them what bothers them about their eyes most, okay? That's my starting point. They're allowed one answer, and I write that down. And that's where we start, and we go from there. I don't know if that's helpful.
That was an answer to an even more important question, which was, what kind of doctor do I need, right? Where are they coming from? What are they thinking about? Everybody that's gotten the black bags here, there's a little yellow handbook in there, and we dig into that topic quite a bit in the handbook as well. What should I be looking for in a doctor? And also the theme you touched on, when this is not a sight-threatening disease, that is an automatic, different kind of framing for the doctor that we have to be mindful of to understand where they're coming from. It helps set up our expectations for what we're going to experience there. So controversial topic number 2, MGD, apropos. This is the dominant theme, I think, online when we're talking about dry eye. We have been hearing statistics for many, many years, 86% or whatever the figure is, I forget, of dry eye is evaporative and so on. And a lot of the focus on treatment is on meibomian glands. I would love to hear from any and all of you on how you feel about that, what you are seeing in your patients, and where meibomian glands fit into the picture.
So this was 20 plus years ago. I was in Texas. Remember I said to you on the phone, I've been pushing on eyelids since 1995. So I'm always very concerned when I see a trend in healthcare. And number one, I think meibomian glands are important to ocular surface homeostasis. Number two, I think people can have problems with their meibomian glands for a variety of reasons. And some of those can be easily addressed. Some of those are more challenging to address. But I actually will tell patients who have really, really grody looking meibomian glands, this is fantastic, because if we can make your meibomian glands better, and I have a plan for that, we can make you feel better, okay? But the trend of claims for medications, fixing meibomian glands, unapproved claims, devices, treatments, when everyone's telling you this is the source of your problem and you have to do a super expensive thing over and over again, my skepticism meter goes higher and higher and higher. And that's particularly true when the in-office treatments are a very positive revenue stream. So nobody likes to think that their doctors are worried about dollars, but we all are. We have to keep our offices open. We're human. And so there are those financial conflicts of interest, which are very present in the modern paradigm of treatment for meibomian gland dysfunction.
So I'd like to answer it with 3 kind of ideas. Number one, just like dry eye, I don't love the word MGD because to me it's a lot of different things in one category. So if you have rosacea and telangiectasias, it may be inflammation driving your MGD. If you used to take Retin-A and your glands are gone, treating inflammation may not be the right thing. If you have Demodex, that's different. And so the first thing is I don't like the word MGD because I don't think it's specific enough. What I prefer is exactly what you see, because that helps figure out how to treat. That's number one. But number two, I think it's important to recognize that I see a lot of people with findings that fit under the umbrella of MGD, and many of them don't have any pain. And so the second thing that we have a hard time with is just because we see something doesn't mean it's causing symptoms. That doesn't mean I don't treat, but if I treat and the symptoms are not better, I say, well, I treated and we tried it and I'm glad we did, but now we need to move on because there could be other causes of your symptoms that are not MGD. And the third part is more is not necessarily better. And I think anecdotally, all of the treatments that are available have helped some people, but we don't have good longitudinal data on what would happen to your glands if you did nothing versus if you did something really expensive. And so I'm more about education. I have no problem with any of the treatments that are out there, but I never want anyone to feel like they have to have it because we don't have any data that long-term it actually changes things or it's better. And we don't have data that manual expression, what I can do with a Q-tip, is inferior to what a fancy machine can do. So I also reassure people, like if you want to go and try something expensive and that's in the cards for you, go ahead, but don't feel like you have to. There are other things that we can do. And until we have really good data to guide us, I think it's kind of whatever works for you personally as long as you understand it. So, you know, these techniques and office-based procedures are there, but I like people to understand that they're not mandatory. And I think that gives people reassurance. And so, again, I do think there are things that we see on the eyelid that fall under the umbrella of MGD, but I want, again, to go further.
Thank you. So talk to me about how we as patients would navigate that. I'm being offered this thing and this thing only. What's my comeback to that?
I love the fact that so many people in this audience seem to be able to do better literature reviews than I can. So the first thing is if you're kind of someone who likes to go to ChatGPT, which I literally just learned about a month ago. That's how behind I am. Now I talk to ChatGPT all day and every day. You know, it's really important to understand where we have data and where we don't. And just know that if there's no data, then it's really up to you. It doesn't mean it's wrong or right, but it means it's not necessarily. So I think the first thing is for people to do homework to see, does this make sense?
I think we're also in an area of exploration with MGD. I don't think it was until more recently that people started using equipment to image the meibomian glands. So with meibography, you know, we're learning more about the anatomy, structure. We're looking at, you know, good images that look a little bit wonky, distorted, cut short. And so it's kind of stimulating us to find solutions. And, you know, companies and our industry reps they're trying to help, and they're, okay, well, what can we do to improve the appearance of those wonky looking meibomian glands that we now see, which we haven't been seeing for the past several decades. So I think people are suddenly jumping on this, this is the cure for dry eye. We're gonna heat the glands, make them straight, just express the heck out of them. And again, for some people where they look all like clogged and gooey and you're squeezing things out, that's a relief that we have tools to heat and express and clean your lid margin, and you have things at home that you can utilize to maintain that good hygiene. But I think sometimes we might be searching too hard for an answer where the problem's not necessarily there. So when I have patients come and they say, I have really bad MGD, I've been treated for it, and I look at their meibomian glands, I'm like, maybe they look a little bit inflamed, but your symptoms don't match with that. I think there's something else going on. We need to dig deeper. So I think helps to start the discussion. I think we're still learning a lot. We're trying to do more controlled studies to look at the impact in different groups of patients, and I don't think we're there yet, but I think technology is getting in front of us a little bit. There's so many new tools and devices and fancy gadgets that look hot and sexy, but may not necessarily be the answer for you particularly.
I think MGD is a construct, and I think there are people who had all the symptoms of dry eye, but who didn't have aqueous deficiency. And with understanding of the tear film and having 3 layers, a mucin layer, a tear layer, and a lipid layer, it's a very good idea. If the tear layer is fine, people were looking for things to help. And why not boost up that lipid layer? And there's ways to image the tear film itself and see the thickness of the layers, and then those lipids come from the meibomium glands. So it makes sense to try to enhance that. What I would say, though, is for the more profoundly symptomatic people who may have, I believe there's something called evaporation hypersensitivity, where your whole body, your nervous system, is oversensitive to the evaporation signaling coming from your eye to your brain that's telling you, well, it doesn't tell you, it's an autonomic thing. You will water, you will secrete, you will blink. And usually that happens to most of us unawares. There are certain people who develop evaporation hypersensitivity where suddenly in the ambient world they're very aware, and this is the pain, right? This is the dry eye pain. You want to crawl in a shell, close your eye. I don't believe any supplementing of the lipid layer is going to solve that. It might be a component to reducing the sensitivity by improving the shielding, but I don't think it's the problem. I think you can have rosacea, as Dr. Galor said, with a big inflammatory problem. You can have loss of the glands from something like Accutane, but I'm not sure that boosting the function, if you believe that massage or compress or all the myriad of treatments is really going to solve the symptoms of most people who have dry eye symptoms but are not aqueous deficient. That's a bit dismissive, I know, but I feel that MGD is a descriptor of a finding. I think it's an opportunity to treat people. People are looking for an answer, but I'm not sure it's a pathologic process. As Dr. Galor tells us, we don't have good data. We don't really know what the natural history of meibomium gland atrophy is with age. There is imaging, and they have sort of age-corrected normals, but we don't actually have good data on what's normal for age. And the imaging may not even correlate with the function, which is hard for us Western people. We believe like an X-ray tells you if a bone is broken. Yes, that's true. But an X-ray doesn't tell you about pain, right? I'm speaking to our radiologist. So looking at the meibomium glands may not actually tell you about the ongoing homeostasis in the whole system. And so I believe it's a little bit of a red herring, and I'm probably going to alienate some people in the room, but I find it a bit of a distraction. Certainly, no harm will come. You know, first do no harm. That's the great medical principle. You're not going to be harmed. Your pocketbook will be a little thinner. Some people feel better when they've spent money. Do you know that in the whole pain field, the placebo effect is something like 35%? Any treatment you offer for any pain syndrome, 35% of people will feel better. So does any one MGD treatment improve more than 35% of people, according to them? Not according to their LipIview, but according to them? That's a good question to ask. Doctor, what fraction of your patients feel better after doing this? I mean, the thing is, a lot of doctors don't react well when you confront them with deficiencies in their data. So it's kind of a difficult path to take. You asked, how do you ask your doctor when they're offering you a treatment? So you might say, gee, I want to think about it. And in your office, Dr. X, what fraction of your patients feel better after this? See if their answer resonates with you, and use that as a guide.
In the Yellow Handbook, we've got some tools for appointment prep and some suggestions there and some ideas about like a really compact set of questions or thoughts you can send in to your doctor ahead of time or following an appointment that might, provide a little space for thinking about it before we engage in the conversations. Separately, a thing that's coming up for me in hearing all of you share on this is that there's a phrase I find myself using a lot talking with patients, and that is emerging science. As in, this is an evolving process. We don't know everything there is to know about meibomian glands. There's a lot of unknowns out there. It's still filling in. We don't have all the data. And that is one of the reasons, too, I think that in what we hear from the community, people get very frustrated when they go to 5 doctors, and all 5 doctors have different answers about their meibomian glands, too. It's okay that none of them is the be-all and end-all and has every answer about this. This is an area of, more learning and more research. Dr. Chiu, you said something about fancy gadgets. And I want to just pick up on that theme and, whoops. There we go. What do you guys use in clinic? How do you diagnose? I mean, I'm kind of remembering your presentation 19 years ago on what does an appointment look like. I mean, what sorts of, I'm always hearing about these new diagnostic tools out there. To what extent do those matter? All right, that's about 10 questions, so.
I'll start. So I work in the Department of Ophthalmology, and it's an academic hospital, and we have everything that you could ever want. And I think I use like 2% of the equipment that we have. But I think making the right diagnosis starts with listening to your patient. So I do surveys for all of my new patients to understand their subjective symptoms in an objective way. We use the OSDI survey, which is done during their workup. So I get a glimpse of how they're feeling, not just how they look. I need my slit lamp, which is a microscope to look at the cornea, the tissue, the integrity, the epithelium, the eyelids. And then I use some vital dyes. I use sodium fluorescein, that yellow thing that all of you have had stuck to your eyes like millions of times, and you leave seeing yellow and orange. I use that. There are also a couple other vital dyes that may be used in other offices, like glycine green and rose bengal. It's hard to get some of those things, so I don't use those very often. But I think you can make, first off, I think it's hard to make a diagnosis in one visit, but I think you can get a good sense by listening to your patient, hearing what they've explored, what has worked for them and what hasn't, to help guide you. And then looking at their eye and looking at them as a whole, how they blink, how their eyelid position is, what their skin is like, and a lot of what they're explaining. So I know there's a lot of tools that can help look at the tear film evaporation. We have meibography looking at meibomian glands. I don't use a lot of that, and I'd love to hear from my ophthalmology colleagues. What do you use?
So I have to say I'm in 100% agreement. I feel like as an ophthalmologist, we love fancy tools, and I have all of them, and I actually use all of them, but I don't need any of them. I think making a good diagnosis starts with a history and a slit lamp exam with a vital dye and some topical anesthetic. But I think that, we have these tools, and I use confocal microscopy to look at the nerves, to look for inflammation. I use meibography to look at the anatomy of the glands, but I don't think you need that in order to make a good diagnosis. So what I tell clinicians when I give talks is whatever you have in your office is enough to do a really good exam and get to the right path for an individual patient. You don't need like an expensive startup package in order to do a good exam. And I think that over the years there's been kind of an over-reliance on technology, and maybe things like getting a good history has been lost. And I think that we need to re-educate our colleagues to start with a good history. I think that's one of the most important things.
So I think I'm the only person here in private practice. We don't buy toys because those toys are super expensive and they're not reimbursed by insurance, and we don't want our patients to pay for a scan that we're not going to utilize. So one helpful thing to be thinking in your head, or you can flat out ask your doctor, if you want me to have this test, and I know you've been upfront with me and it's going to cost me $175, how is it going to change my management? And what I've heard from my 2 esteemed colleagues at the end of the row is that it's fun to have these images, but it almost never changes management. So the take home here is that if you go to a doctor who is not performing all of these elaborate tests, these tear film analyses and what have you, mybomography, they're not old-fashioned or inferior, especially if they use the time that would have been dedicated to dragging you to a testing suite to actually talk to you.
Yeah, I agree. I'm in an academic setting, but for whatever reason, we don't have every toy. We have to, we don't have everything. We have to justify it. I'm on the Capital Equipment Acquisition Committee, so I understand and have to say yes or no to different things in different order. I think that some of these diagnostic modalities or tests are helpful because they provide information. I think that in certain settings, particularly at academic centers, when the doctor is also investigator conducting research, it's important to collect all this information because it can be used in retrospective studies and going forward studies. And I have participated in clinical care where every patient got a survey on intake. And every patient got it the same one 6 months later to find out the impact. That's how we showed the impact of the scleral lens prosthetic device, now called PROS treatment. So I've done that, and the survey was critical. Do I do surveys now in my clinical practice? No, because I'm not doing research. So I think there's value to each of those things at different times for different purposes. But I think you can get very good care for your ocular surface disease, not your dry eye, because I still don't know what that is, for your ocular surface disease by having a good clinician who's willing to take an interest. And I'll say one thing. I mean, we talk about taking a history. I generally review my charts the night before because I have to put in Epic what tests are that I want, and it's better to do that before. I don't have a whole retinue of tests that I do for everybody. And I read whatever the referral notes are on a new patient, either from the referring doc or if patients self-refer, I read that. But what I find really useful is I look at their systemic med lists, because that tells me something about the whole person that's about to be walking into the room. And I get more clues from that. And I can tell you for sure, most eye doctors, MDs or ODs, do not look at the systemic med list before they see a patient. It's not efficient. It's not,
I do.
You do, okay. All right. Well, but I mean, and it's, I think it's really important, but most of us in our busy day think we're looking for sight-threatening disease. And I don't even start with the slit lamp. I mean, I walk in the room. I've made some of my best diagnoses about essential blood. People come telling me they have dry eye, and really they've got essential blepharospasm, or really they've got atopy. I look at their hands. A lot of my exam is before the slit lamp. The slit lamp is the courtesy to the patient. I mean, that's a little bit of a joke, but not really. I do want a magnified view of the eye, and I do use fluorescein. I actually do use lissamine green. I do anesthetic challenge, which I find very useful in sorting out where the systems are coming from. I do Schirmer test. I've been dumbfounded in the past year, the number of people who come to me saying they're told they have dry eye. They've been on this, that, and the other thing, and they've never had a Schirmer test. I'm dumbfounded, because you really have to know if someone's, I mean, I don't know how to tell you what a Schirmer of 8 means compared to a Schirmer of 10 or 12, but I do need to know if you're in the single digits or over 20. That changes everything. But Schirmer test is low tech, it's not sensitive, it's not scientific, people feel it's old fashioned, there's a million different ways to do it. So people stop doing it. Yet they'll drink the Kool-Aid and buy a mybomographer and charge you, or I don't know. People just roll it in. I don't know how it's paid for. Does insurance pay for meibomogram imaging?
It's tricky.
I'm sorry?
It's tricky to get
It's
it covered.
tricky, right, yeah. So, you know, these are profit centers for practices. I've never been into profit. You know, I like to eat and feed my family and buy a nice outfit sometimes. But so how much of this is profit driven? How much of this is knowledge driven? How much of this is care driven? Really varies. And I can't malign all of it at once. Each has its value in different places. But the question, how is it going to change what you're going to do? That's a very, very important one, I think, when you have a decision about whether or not to spend out-of-pocket money for an extra diagnostic test. And we won't get more knowledge if we don't have more information. But I'd like more information maybe about primary symptoms in driving where the workup and treatment goes. What's your main symptom? That helps me. When I ask for that one sentence, what bothers you most about your eyes? And I ask that face to face. I mean, I know my tech has asked stuff and I read what's written there, but I sit and I look at the patient face to face. I say, what bothers you most about your eyes? And they can't have a litany, one sentence, one phrase. Then we have a place we're going.
And briefly, I just want to clarify that these are diagnostic tools for like the front of the eye and ocular surface and tear film. None of us here are retina or glaucoma specialists, but in those parts of the eye, I think imaging and technology is essential, doing scans of the layers of the retina, looking at the optic nerve and visual field. So that's a different part of eye care that we should clarify, that diagnostic tools and equipment are essential there.
And there's a tool that Dr. Galor mentioned, the confocal microscope. I have that toy, 70,000 toy, and you need a skilled operator, and you need to know how to interpret it. But people think it's magic for diagnosing pain. They think it's like the crystal ball. And that's another topic that I sometimes have to dispute. It's giving us information, but it's not a validated yes-no test. And in fact, we got it because we thought we were looking at nerves, right? We wanted to study nerves. But the way I use it, and Anat and we don't actually talk that much, but when we do see each other in settings like this, we find we agree on everything. So I found the confocal useful to look for inflammation. I do look at the nerves, and sometimes I learn something. But if I've supplied a surprising amount of inflammation, that's going to direct me somewhere. If I find zero inflammation, that directs me somewhere else. So sometimes we don't know what the tool will tell us until we start using it. And the confocal is an example of that. But I'm now getting referred patients. They're sent to me because their doctor thinks they might have neuropathic pain, but they don't have a confocal. And I'm like, oh. It's not the confocal that's going to give us a yes-no answer. It's the clinical assessment. And instead of categorizing it of this is what I send there and this is what I send there, could you all please try to take care of the person in front of us? But it's a very hard thing to do in the American healthcare system, and probably in the UK and elsewhere. We're all busy with throughputs. There aren't enough clinicians. It's a big issue.
This has been an amazing discussion. Can we thank them for it's really terrific.